Hello everyone. I'm going to talk about contemporary alignment techniques in total knee arthroplasty. I'm a third-year orthopedic resident and first-year PhD student from Székesfehérvár, and I am interested in the treatment and management of osteoarthritis, and I have a special interest in hip and knee replacements. In my PhD, I'd like to compare two techniques in total knee replacements called the kinematic and mechanical alignment techniques. And to achieve my goal, I've been conducting a systematic review and meta-analysis, and after this I'd like to run a randomized controlled trial. In my first project, I'm comparing the safety and effectiveness of kinematic alignment and mechanical alignment in total knee arthroplasty. By the way, arthroplasty is a fancy word for total joint replacements. So the problem is that we have over 300 million people suffering from knee osteoarthritis globally, and the gold standard treatment for end-stage painful knee osteoarthritis is total knee replacements. So despite the immense number of operations and clinical experience, the number of dissatisfied patients after the operation is still high. It's about one in 5 patients, and we don't really know why. Now there is a debate about which alignment method is best for the patient. So we've been using the mechanical alignment for decades because it's safe, reproducible, easy technique, but it's a kind of a one-size-fits approach. And as you can see, the one-size-fits approach won't necessarily fit the outlier patients with different deformities. So personalized approaches such as the kinematic alignment have been developed more recently, and we'd like to compare these techniques. Now, the critiques of the kinematic alignment argue that, okay, it's personalized, but it leaves too much deformity in the knee, and which could lead to uneven loading on the implant and early loosening, increased revision rate. So that's the biggest fear, and people who like the philosophy of kinematic alignment but fear the consequences actually came up with the restricted kinematic alignment to don't go beyond certain boundaries, but basically they don't want to leave the leg in a plus or minus 3 degrees deformity. So they are trying to stay within safe zones. So in my project, I'm asking, is this personalized kinematic approach going to lead to improved clinical outcomes compared to the traditional mechanical alignment? And our hypothesis is that yes, it should, because it's more personalized approach. So that's our hypothesis. We've conducted a systematic search in 3 databases, and that resulted in over 3,300 results. After selection, we had 18 randomized controlled trials. So my first plot is showing the Oxford knee score. This is a questionnaire for patients after the operation about pain during different daily activities, such as walking up and down stairs, walking on uneven surfaces. And this is a patient-reported outcome from 0 to 48. As we can see, after 1 or 2 years, the overall effect is about a score of 2 favoring kinematic alignment, even including the outlier studies in the unrestricted group. And we can say that this has modest clinical relevance and didn't reach mathematical significance. However, the WOMAC score, which is very, very similar to the Oxford knee score, but it has more questions in the questionnaire, so potentially a little bit more sensitive, actually is showing different results. So when we did the subgroup analysis, we can see that in the unrestricted group, the effect is much greater, the overall effect is much greater, and also reached statistical significance. So the WOMAC score is from 0 to 100, and the overall effect is 10. And we can say that has clinical relevance and also mathematically verified. In the forgotten joint score, we are asking patients how much they remember during the day that they have an artificial joint. So it's a score from 0 to 100, and the higher the score, the better is the result. We can see that the overall effect is modest on a scale of 0 to 100. But it did reach clinical statistical significance, and it does align our theory that kinematic alignment preserves the native anatomy more, so the overall feeling will be more natural and the proprioception will be preserved. Also, just jumping back to this slide, actually here higher scores represent worse results, so just to clarify, that's why it's on the mechanical side. So my next outcome is flexion. Flexion is an important measure of function after the operation. In healthy population, the flexion, how much you can bend your knee, is about 140, 150. In osteoarthritis, it's reduced to 100 degrees. After the operation, we are aiming for something between 110, 130. That's acceptable outcome. And we can see that at 1 and 2 year follow-up, the overall effect of using the kinematic alignment resulted in an improvement of 4.5 degrees. But when we do the subgroup analysis, we can see that in the unrestricted group, without the boundaries, this effect is even greater and also reaches statistical significance. Now, the hip-knee ankle axis, or the limb alignment, which I've been talking about. So does kinematic alignment leave your limb in an unsafe manner, which could result in early revision? And actually, what we can see is that when we pooled 10 studies and about 900 patients, the overall effect of using the kinematic alignment compared to the mechanical alignment is only about half degrees. So it's well within that 3 degrees of safe zone, plus or minus safe zone. The overall effect is only 0.5 degrees. And so this is against the theory that kinematic alignment is unsafe and leave your limbs in a crooked, deformed position. Now, is it going to lead to early revision rate, an increased revision rate? And when we have pooled 9 studies and over 1,000 patients' results, we can see that at 1 or 2 years follow-up period, there was a slight trend towards all-cause reoperation in the kinematic alignment group, but it didn't reach statistical significance. So we can conclude that there is a potential mobility benefit for using kinematic alignment, it's important to differentiate between the different types of kinematic alignment, which hasn't been done before, because they give different results. But currently, both, or actually all 3 techniques can be used safely at short-term follow-up. And in the future, randomized controlled trials should focus on subgroups such as based on age and gender and specific knee anatomy to identify which patient groups benefit from which alignment technique the most. That's the progress of my first project. And in my second project, I'd like to compare the safety and effectiveness of inverse kinematic alignment and mechanical alignment by running a randomized controlled trial. So as we can see, there is a shifting paradigm towards more personalized approaches, and this is followed by a trend of increasing use of advanced, expensive technologies such as robotic-assisted technologies. And these technologies enable us to use, again, different alignment methods. And one of the newest ones is the inverse kinematic alignment, but we don't really have a direct comparison between inverse kinematic and mechanical alignment methods. So my goal would be to directly compare these 2 methods in a randomized controlled trial. Basically, the big question is this expensive technology justified by improved outcomes, less pain, and maybe even reduced complications and reoperation rate? So in summary, in my PhD, I'm comparing different techniques in total knee replacement, and my first project is nearing its end, and I'm planning, I hope I can submit the protocol for my randomized controlled trial by the end of this year. And I'd like to finish with a quote from Rodney Smith, who was a famous orthopedic surgeon. And I think this quote is important in this era of advancements and rapidly changing technologies. I firmly believe that the best possible operation is not the same thing as the best operation possible. Thank you.
Thank you so much, Nándor. Any questions from the committee? I have a short question for you, Nándor. So, surgical success or safety and efficacy of surgical interventions is highly dependent on the skill level of the surgeon and also the perioperative management of the patients. Do you have any remarks on that about the included studies where the perioperative management and surgical skills vary?
Yes, potentially. There were certain variations which could have resulted in the heterogeneity that we could see in some of the plots. It's a very good question, and this could be, for me as well, a future interest to identify perioperative protocols which lead to better outcomes. So yes, it could lead to, it has a major role. In these studies, the perioperative management is not well documented, but your question is very good.
A follow-up question
Yes.
or a comment
Yes.
would be that if you wish to run your randomized controlled trial in the university, I would very much recommend implementing an enhanced recovery after surgery protocol to reduce confounding in the randomized controlled trial.
Thank you.
Any questions from the audience?
Yes, so after I have seen your result, you said that the risk of reoperation in the first
Yes.
2 years is
Yes.
higher with kinematic alignment,
There's a
but
trend,
not
yeah.
mathematically significant.
Yes.
Do you have like longer follow-up times, like 5 years, 10 years? Maybe there will be more
Yes,
difference.
absolutely, and we do have a longer follow-up period for some of these RCTs, which we couldn't pool in the overall meta-analysis, but we want to discuss this with the statisticians. But from what I've seen so far, their argument is that there isn't an increased rate of reoperation with kinematic alignment in the long term, even at 10, 15 years at the moment. Yeah.
Okay, so this is the higher at 1 or 2 years.
Yeah.
And it not goes higher.
The follow-up period?
No.
Yeah.
The risk of
Yeah, it
reoperation.
doesn't go higher. No, at present.